Thank you for joining us, and thank you for allowing me the opportunity to speak to you tonight. I am the medical director of the Trauma Center at St. Luke's Cornwall Hospital in Newburgh. I've been the medical director there for 8 years and have been the only director there. We started the Trauma Center 8 years ago. I have been at St. Luke's for about 18 years, and I live in Newburgh as well. And thank you for coming along tonight. When you think about trauma centers, a lot of people, the first thing they think about is gunshot wounds, stab wounds, horrible car crashes, and that sort of thing. And certainly we take care of that at St. Luke's, as other trauma centers do. But for us, as well as every trauma center across the board in the United States, falls are the number one cause of trauma center visits, as well as admissions, far and away the number one cause of admissions for us. And all other trauma centers across the country are the same. How big of a problem is this? Well, it's the leading cause of death by injury in people over the age of 65. Certainly, there are other causes of death that far outstrip that: heart disease, cancers, and things like that. But death by injury in those greater than 65, it's definitely the leading cause of fatality. Two-thirds of people over the age of 85 who have a fatality from an injury, it's secondary to fall, and leading to over 8,000 deaths annually in the United States. What kind of injuries talking about? Well, mostly the issue is the fall, but then there's the what happens once somebody falls. So leading cause of hip fractures in the elderly population, and pelvis fractures, and that's from striking the ground. And people try to catch their fall and prevent the fall, and will incur or cause wrist injuries, numerous, that's upper extremity or arm fractures as well. Causes almost 250,000 of hip fractures and an equal number of wrist fractures in this country on an annual basis. And when you look at it from the big picture point of view, less than 1% of falls actually result in hip fractures, and only 5 to 10% of falls require medical attention. And what that implies is that people who fall, there's mostly they do okay. And when you look at the number of hip fractures and injuries that actually get admitted compared to the likelihood of getting an injury, it really means that people are falling multiple times. And there's a great number of falls, and eventually people, will unfortunately get an injury and require admission. But the number of falls far outstrip the actual number of injuries and admissions to the hospital. And how often does this happen? 25% of people over the age of 65 up to 75 fell once in the last 12 months. Over 75, that's almost a third of people. And the numbers, that's at least once. Some of these people, or many of these people, have fallen multiple times. And when you're in a position where you're seeing people with injuries in the hospital, and you will see people who will have multiple admissions, multiple emergency department visits for recurrent falls. And these are people typically who are living at home. And what's the impact for persons greater than the age of 65? We're talking about millions of injuries in the United States on an annual basis, with millions of days of restricted activity, people who are confined to home because of their fall, or have some short-term and sometimes long-term disability secondary to their fall, millions of hospital admission days, time spent in the hospital, and people admitted to fall, maybe half of them are able to go home. Greater than 50% of them actually have to go to rehab after their fall. What are the risk factors? Well, demographically, men over the age of 80 years old are at particular risk for fall. And why is that? Well, likely because of some risk-taking behavior. So men have an older gentlemen, as well as younger people, have a tendency to take risk more so than women. And when an 18-year-old drives a car way too fast, they certainly put themselves in position to get hurt. And then things never change. So as we get older, things like climbing ladders and uh, getting on standing stools to reach things at home, put them at risk, and they certainly are at higher risk for falls and injuries. People who have impaired activities of daily living, so that's what ADL means. So people who need assistance or have difficulty getting along on their day-to-day activities have a 14 times risk of falls at home. And people who have a history of falls. As I said before, you see people with multiple ER visits because of falls, and a fall puts you at risk for further fall. So that brings to light the opportunity for intervention, the opportunity to identify why people are falling, and hopefully to intervene and prevent further falls in the future, and therefore reduce the risk of injury as time goes on for an individual. There's medical reasons. People with dementia, people with Parkinson's disease are at particular risk for fall. People who have incontinence are at risk for fall, likely because they have more frequent trips to the bathroom at night in the dark, that sort of thing puts them at risk for fall. People with musculoskeletal and sensory issues, people who become weak, people who, as they get older, don't maintain their strength and become frail, and that's a measurable thing, frailty, as people get older. And you can see people who have a weakness with their grip strength, difficulty in grasping objects and maintaining their balance and avoiding fall. People who have reduced lower extremity strength, people who may not be able to ambulate as well or maintain their balance are at risk for fall. If you can't see, if you have visual impairments or difficulty in ambulation and your gait is impaired, you're at particular risk for fall as well. And the big one is medications, anything that's like a sedative, anxiety medications, anti-Parkinson's medications, that sort of thing puts you at risk for fall. As you have more medications on board, the more medications you use, regardless of what type of medication, the more medications you have, the more likely you are to be at risk for fall. And the situational risk factors. Healthy older people, they may engage, as we spoke before, as in risk-taking behaviors. So I, see a lot of patients who I'll be told that that their family member is elderly and that they are always got onto the ladder to clean out the gutters every year. But people forget that as we get older, your ability to do those kinds of things, those functions, become a little bit more difficult. And that's because of physical limitations and because of your sensorium type of limitations. You may not be aware of your surroundings as well as you were when you were younger. And these behaviors will dramatically increase your risk for fall. And people are more likely to fall away from home, likely because they're not used to those surroundings. And it's a different situation, different scenario, locations and areas where they're not used to, and that puts them at particular risk as well. And people with impaired mobility. So this is typically like your nursing home patient, somebody who needs assistance moving from bed to a wheelchair, or assistance in getting into the bathroom, transferring from a wheelchair to the bed, and vice versa. Those always are opportunities to fall. There's a particular risk factors for falling. And people have a changing perception of risk. People get older, they don't understand and realize what the risk is in their activities. So things that we used to be able to do as we get older, maybe carrying more risks than we appreciate. Not just the patients, not just the people who fall themselves, but also the family needs to be aware of that, that their loved ones may be engaging in activities that at this point in their life may be far more risky, far more putting them at risk for fall than everyone appreciates. And people have changing abilities for a task. In other words, they no longer have the ability to perform the task that they once had, or do it as well, or do it as safely as they used to, and that's because of medical limitations. So how do we prevent this sort of thing? Well, I mean, and if you look at what's been researched, a lot of good suggestions out there on what we can do, particularly prospectively for people in order to avoid fall. But to be honest, a lot of the data has not really clearly proven to reduce risk. However, it doesn't mean it should be ignored. So the literature doesn't 100% support a lot of things, but a lot of studies have pointed us in the right direction of how we can intervene and prevent falls in the future. Strength of somebody's strength level, particularly lower extremity strength and somewhat grip strength. If it's impaired, it's a strong predictor of people having falls. So if you have the weakness, as we said before, of your grip strength, unable to maintain your balance, grasp onto handrails, banisters on the stairs, and that sort of thing, puts you at significant risk for falls. And the good news is that improving your grip strength likely reduces your risk of fall and injury. And people who are elderly who engage in exercise very much benefit from that exercise and improved strength training. Even, and I'm not talking just over 65 people, even people into their 80s and 90s, even moderate exercise and strength training can certainly improve a lot of things, not only your mental and physical function, but also reduce your risk of falls and injuries. So a little bit goes a long way. So it's certainly something that we would look to engage patients in if they are at risk for fall. Balance and gait, as time goes on, people may have difficulty with balance. It's something that's often taken for granted when one is younger, but things can become impaired as people get older, when you introduce medications into their life, and certain things that become dysfunctional. So most of your balance is revolves around the function of your middle ear. From a technical point of view, it's a vestibulocochlear system. But what's critical about that is that when we're evaluating somebody for their balance and looking for issues with that, the first order of business is actually evaluation by an ears, nose, and throat doctor, and make sure that everything in the middle ear is functioning okay, and then that's not the root cause of what's going on with balance. Things like exercise and physical therapy and training, teaching methods to walk more safely and ambulate more safely with or without assistance, be that a cane or a walker, does improve the situation. Your gait, your ambulation does improve with that treatment and therapy, and your risk of falls does decrease. St. Luke's does have a balance center, so patients who are at risk for fall or have fallen and incurred injuries can be evaluated there. And again, it goes back to first order of business to look at medical issues through ears, nose, and throat doctor, as well as possibly a neurologist to make sure that there's no treatable medical issues going on. And then further evaluation and treatment with physical therapy and training can certainly reduce the risk of fall and improve the quality of life at the same time. So there's a lot of benefit to this. Medications are a huge potential issue for fall risk. particularly your psychotropic medications. These are your pain medications, your sedatives. Those are your benzodiazepines, your Valiums, your Verseds, your Ativans, Parkinson's medications. All of these will put you at significant risk potentially for fall. And what happens is that as time goes on, people take medications. So I will not infrequently see people who have had a fall. Maybe they've had injuries from their fall, and they've been on medications for the last 20 years, and it was prescribed to them appropriately 20 years ago. But over the years, I just continued to take that medication, and the alternative treatments that may be offered as one gets older, or changes in the dose or how long they're being treated, has not been looked at. So it's critical that as people get older, we look at them as a different population. Okay, so just as we look at children as a different population, as different from adult patients, as people get older, it's crucial that we look at the special risks that the elderly population has, and their unique needs and risks. And this includes particularly medications. And there's things like the Beers list of medications, which are really the high risk medications that are often looked at by someone who is or is trained in geriatric medication, with being mindful of the needs and particular risks of the elderly population. Environmental issues, home, uh, the physical environment of people at home can potentially put them at risk for fall as well. And there's the opportunity for certain people to assess people's home environments, to assess them for risk. Um, things, and they're usually pretty simple things that, again, just like medications, just carry on and on and on and don't get changed or looked at. The home environment, people will live in a certain environment and not think about how, as they age, that environment may at some point put them at risk for fall. So things like adequate lighting in the home, stairways that are need repair, the outside sidewalk that need repair, having things like grab bars in the bathroom. Bathrooms are very commonplace for fall, particularly getting in and out of a tub or the toilet, and having bars to stabilize yourself and assist with your transfer from one location to another and getting to a standing position are critical, as are non-skid bathroom surfaces. There's behavioral things such as clothing and poor footwear that people will use, and this needs attention. And even simple things like having poor vision, not being able to see clearly, not being able to see the stairs adequately, um, can certainly put you at high risk for fall. And falls downstairs are common things. I see patients all the time who are elderly who fall down the stairs, and the injuries can be significant. Once they call me to see the patient, and we've usually got some pretty significant injuries going on, including rib fractures and spine fractures, along with all the hip fractures and other things going on. So addressing these things prospectively is critical in reducing those risks, and not only educate the people involved, but the family as well. So this really is um, a family oriented thing, where what's mom and dad happening at their home, and is the home safe for their day-to-day living? Is the lighting adequate? Is the bathroom set up for somebody who may have difficulty negotiating the bathroom? And it involves not only the patient, who may or may not be aware, or who may not appreciate the risk that they're at. So the family being engaged is critical as well, and they can intervene and become educated and identify opportunities to reduce risk for fall. And I know my dad is 88 years old, so and he lives independently, but I've made sure that his home is as safe as can be, so that he continues to live independently and not fall. Um, so really, looking at it from a big picture, you're it's really is a multifactorial issue. It's identifying people who are at risk, identifying opportunities from a medical point of view to intervene. Now, a lot of that revolves around changing behaviors and particularly changing medications for patients, and that's actually a big deal, a big cause of falls, and identifying those people at risk and assessing that risk. Getting involved with people who are trained in identifying risks for the elderly population for falls and other injuries, appreciating the particular needs of the elderly population, being trained in geriatric medicine or having experience in geriatric medicine is a critical component. It involves identifying medical problems, identifying opportunities for intervening with physical therapy and further training, balance testing and assessment, as well as identifying opportunities for improvement in the home to reduce risk for fall. And that's what I have for tonight. And I appreciate you attending, and thank you for your time.